So you guys, Karthik, PK, Raman?
Yeah, hi
Hey,
George.
how are you?
Hi
Guys.
George.
Hey, George, how are you? So
doing
Raman,
good.
myself, Karthik are here, and would like to just correct Jazz that, it's not only about the coronaries, because the peripheral still pays all the bills. I think Craig can attest to some of that. But, we've got a great case to showcase to all you guys about what we're doing. And, before that, I'd like to introduce, obviously, everybody knows Karthik Guja to my right, and to his right, Raman Sharma. It's been our team for many years. We've got our nurse, who's here, Elaine is there, and then we've got Christina, and we've got Francisco outside. And of course, we've got our wonderful endovascular fellow, Mike here. And, we've got 3 fellows this year, George. So maybe you could tell us about your panel, and we'll get started.
Yeah, so to my left is Craig Walker, who needs no introduction. And we've got Eric Dipple, Jay Matthews, and Ish Thomas, Steely Lesteriades, my Greek brother from another mother, and Dr. Wesley Oman to keep us all straight from the vascular surgery department.
Oh, that's awesome.
He's our teacher. He's gonna.
This is great because this has a lot of vascular surgery implications. So I'm glad that Wes is with us. Without further ado, I'm just going to go ahead and ask Michael to present the case since we lost a few minutes with the last case.
Okay, so this is a 70-year-old woman that initially presented with right lower extremity claudication. She was recommended a supervised exercise program, however was unfortunately lost to follow-up. When she reestablished, the patient complained of lifestyle-limiting claudication that progressed to ischemic rest pain. Past medical history of hypertension, hyperlipidemia, diabetes, non-ischemic cardiomyopathy with an EF of 30%, CKD on 4 liters, CKD stage 3B, colon cancer remission. She does have a past medical history, past surgical history of a left external iliac artery stent, as well as she's a former smoker. She's on a variety of cardiovascular medications. Her initial diagnostic evaluation in 2024 was not particularly remarkable, with an ABI of 0.77 on the right, 0.72 on the left in 2024. In duplex ultrasound with slightly abnormal elevated velocities in external iliac arteries with monophasic waveforms distally. As I mentioned, she was lost to follow-up. Given a progression of symptoms, we brought her back to the lab, and these are her angios.
So a couple of things here, guys. So we medically managed her for about 2 years, and she kept on progressing to the point where she's now honestly can't walk more than 50 feet without stopping because of her claudication. So at this time we brought her back, and I'm going to let Karthik and Raman go over the angiogram here.
Yep. So this is the last intervention that she had.
No, this is the access.
The stent was the one that was taken care of last time. And we see the angiogram now, the iliac bifurcation, and we can see 2 things here on the right side. We see the common iliac on the right. It's patent with a large, very, very large and robust collateral provided by the internal iliac, and you see a small nub of that proximal external iliac on the right. But then more pronounced, if you see, is this reconstitution, which is again supplied almost entirely by the internal iliac, and we see the profunda and SFA, and we see a small nub of that distal common femoral. So if you can see it pretty nicely here, that proximal nub of the external at about 15, and then you have that distal nub of that common femoral on the right. Again, just about 1 centimeter of landing zone on both sides. Approximately with a very robust internal iliac that's basically her lifeline as of this point. So right now we have an 8 French sheath up and over from the left side. And we have an aqua tempo with and just a Confianza wire, and we're just about to get started.
And this is the SFA pictures.
Oh yeah, and let's see.
Maybe you can do that, Karthik.
Yeah, SFA is clean. He has pretty much 2 vessel runoff.
This is the SFA.
The proximal SFA has some disease, moderate disease, but pretty much most of the SFA seems pretty reasonably good, just mild diffuse disease. And then runoff-wise, he has a robust PT and a peroneal. AT also comes in, but slow runoff. Hopefully, we are assuming after we fix the iliac, the runoff is going to be much more robust. But the foot gets major vessel into the foot is the PT.
No, but I think the AT and the peroneal are just coming in slowly.
Slowly, yeah.
Slow.
Yeah. So at this stage, obviously we work as a team here. We spoke with our vascular surgery colleagues and was evaluated by anesthesia because of her history of COPD is the main reason why that she was declined for surgery. So with that, we then decided to make her a live case for ARCH because I thought the discussion would be great. Just wanted to show you guys the common femoral reconstitution. It's still common femoral lesion, but we do have a bifurcation that's patent with the internal, with the profunda and the SFA seen. So at this stage, George, what our plan is, and I'm going to start working, we've got an Aquatemco up and over. We're starting with a 014 Confianza wire, just because we don't want to dissect into the common femoral and get into that bifurcation. We're ready for direct SFA access if we need to come from below rather than pedal, just to give us a little bit more pushability in case we need it. But I think at this stage, hopefully we cross with this. And, our fellows got some nice presentations with some data regarding common femoral and external iliac and internal iliac, iliac disease. So you guys can tell us what you would do, but we're just going to get started if that's okay with you.
Yeah, so we'll get some opinions here. I had a similar case relatively recently.
Okay, it's going nice.
Did a hybrid with vascular surgery. So
Nice.
we exposed the common
Zoom out.
femoral,
Yeah, just go.
and then I came around from the arm and went to a common iliac
Give me a
occlusion.
little. Let's do a little roadmap here.
So I think the hybrid way to do it is
A little
not
bit more down, no?
the way to do it. And I think the most important thing that PK said.
Probably I was
is
too
that
low,
we
huh?
talked
Yeah.
to
Yeah,
Sorry,
a little
about
bit too
that.
low.
A little bit lower.
I think that is probably step
There you
one.
go.
At
Yeah,
least
that's better.
talk to the
Yeah.
vascular surgery.
That's better.
So Craig,
Yeah,
point.
I agree totally. Now, I like crossing these better from above than below. And the reason I like that, often if one goes from below, you will get outside and want to dissect up the aortic wall.
Very low.
So I do like
We're going the
this.
same direction though.
By splaying this out, by going opposite obliquity, he showed the nub here. Now he's going to go through this. Now I like to use a less aggressive wire to start with up here rather than a very super aggressive wire first. Often we can feel our way through these big
Very
vessels.
smooth.
Looks like he's making nice
Better.
headway here
Yep.
with this
Sounds
wire.
good.
Down a little lower.
Yeah, I
This
was
is a
no.
case to beware of. Okay.
Let's
so
go a little bit.
there is
Hello,
common-
are
there is
you?
common
Yeah,
femoral
I definitely
lesion,
agree.
yes.
Definitely
But
I was, no?
notice the common
Oh, yeah.
femoral
Yeah,
does
make sure
not
it's not
involve the
thrombus.
origins
If it
of the
crosses, we'll just do
SFA
a
and
itis.
profunda.
Yeah.
Common femorals that involve the SFA and profunda are a different animal than those that do not involve those two vessels.
Perfect.
So
Got
I think
one.
that's
Just
very
goes right.
important. But the other thing is can be very important in this case to either IVUS or to go up with a small balloon first and
Get
then
your catheter a
maybe
little bit further?
escalate
Yeah,
little
I don't
bit,
want to take the
paying
035.
attention to pain. If one goes up
Give me
in a
that
pace
014.
like this is a little
018.
longer,
Yeah, get an 014.
and you go up with a balloon
Right
and
and
you
see.
feel pain,
Looks okay, PK.
beware because the
gonna
next
go
step
kind of
may be
eccentric.
It's going to go on the side.
rupture, and that can result in death.
I got it.
So
I got
it's
it.
very important to take this very
I got
carefully,
this. I can flow
to
right
try
now.
to cross this intraluminally if possible, to dilate this very, very carefully, and to make sure, despite doing all those things, that you have a covered stent in the room.
Get us
Ready to deal
the
with this.
018
Is it
penetration.
0 and 4?
Oh, give me an 014 catheter. Trailblazer in the back.
It's currently
You want the 0 and 4 or 0 and
018,
8?
just in case we can.
Yeah, 0 yeah.
I want to use the
0 and
tracker.
8 is in the back, yeah.
Oh, and 8?
We have an 014 tracker or no? I mean, penetration?
Right there. That's the 0 and 8 penetration, which we have on
Do we
the
have an
table.
014 penetration?
Yeah, we,
And
Okay.
I wired down through there, and the wire went very easily. I didn't think there was any problems. And I IVUSed it, and the wire was clearly tracking out of the artery for a couple centimeters, and it came back in. And I pulled the wire back, and I rewired it. And so I would not even inflate a balloon here until you IVUS this and guarantee
Hold it.
that you're in the correct lumen.
So Jay, I got a question for you. We talk about this all the time. We've talked a lot about CT on the coronary side. I think these sorts of lesions are where CT really can help you because if it's relatively soft in between the caps, then you
Coming down,
Let's
yeah.
get the penetration now.
If you penetrate the cap, it's going to be smooth sailing. If it's
You have 014?
calcified, then you work
penetration?
on stuff.
this is,
Oh, I need the penetration because we can move it nicely.
And I mean, I
that's
think
0 and 8
you don't
penetration,
want
okay,
to
PK?
exit out of that distal cap until you're 100% sure that it's working. Because if you're not, and you just keep going with that wire, you're just going to complicate that connection down and compromise
This way, the other way, the other way.
The other way is it?
I gave you the tip, yeah. We shaped the tip, no?
I know, I'm just trying to see which side it is.
This side.
That's where external duplex.
The other way.
That's
Can you guys raise our volume a little?
Yeah, very, very quiet.
And that can make sure you stay within the vessel. Because external duplex will see through the area of total occlusion. this is angiography, which shows you patency.
The room up again.
Show you that.
Yeah, so Wes, from a vascular surgery perspective, what do you think about this?
Yeah, I mean, the patient's guiding the decision making here. It's really more, we don't like to admit it, but anesthesia is guiding the risk. It is possible to do a femoral endarterectomy under local in the right patient. COPD, not necessarily a clinical indication out and out, but if the patient can tolerate
I don't want to get into the profunda there.
it's a perfect approach.
I don't think so.
I do agree with Craig, excuse me. I think you have to make sure, however you do it, that you're
Can I bring the
not
catheter down?
propagating that
Hold
dissection
it.
flap before you get to the distal cap, because these are the lesions that you have a chance of maintaining some degree of patency, and it's really once you start getting into bifurcation stenting, that's where it's only a matter of time until someone like me has to get involved. Whether it's positioning, whether it's not compliance with medication, what have you, we know that the patency really goes down once you start getting to that.
And there's also the issue if you have an image that and you've dissected that you could shut the door on the profunda when you stent across it too. So
For sure. So in this spot here, once again, I'm going to iterate. I think if you can use external duplex as well, it can guide you to make sure you that you're re-entering this at the right spot.
Yeah, that's exactly what we're doing, Craig. We've got the external duplex now. So the wire we chose was Raman and I decided on going with the Confianza first, and then Karthik and our discussion, we decided to go with the penetration to get through that mid area. And I agree with Eric. Sometimes they go in and out. So in this particular lesion, as you can see, we're very prepared not to extend the dissection down into the. 1 second, let me just try as you get everything ready. So while Karthik gets everything ready, we're just going to try one time here. And if this wire gives us any trouble, we're just going to go and get distal access and come back and cross in the dissection plane rather than in the what is it called, in the vessel. Let me see. See, I don't like the way that feels. Yeah. I don't like it at all. So I'm just going to go ahead and pull back a little. And I think this is where a little bit of patience has to occur to try to find different planes to come. And you saw how smooth the wire is moving. So the question is, whether you guys would get SFA access here or what you would do different. Nope.
Try it or not.
I usually try for a couple minutes, but if one of the problems if you keep poking is you're going to end up just with a big dissection plane, and you're going to lose all tactile feel of the wire because the wire is just floating in free space.
Yeah, I totally agree. So what we're going to do is, we could do angiographic or ultrasound, whatever you guys like. But here, I think Karthik wants to do angiographic access. So we're going to pull out here, and I don't know what we're going to use. I don't think you can see our ultrasound machine. But we're just, so Karthik is tracing the, maybe you could talk through it, Karthik.
Yeah, so, it's a pretty reasonably sized.
Push up.
Yeah, so. I don't think they can see
Meaning
it.
runway. Make sure you get it.
Yeah, we just we try to track it from the bifurcation, see where the bifurcation happens, and of course the medial most is our SFA, and we look at the SFA. It's hard to get profunda access. You should be really good with ultrasound, but the SFA is the most visible one, and I think it's pretty. And
so the key here is to make sure you got enough runway to get your catheter in. So I just want to make sure that we're not sticking too high close to the common femoral. Give me a little die. So which I think is very important because we need to get the sheath in, or even O18 catheter. We just need to have enough wire purchase to be able to use the O18 catheter. So I think about here is a good place to stick. So I'm going to move this out of the way for Karthik. So this way he can go ahead and stick with the. Use a long needle because she's.
So your plan is your plan is solely to cross from below, and you're gonna gain access to the wire and then still fix it from top down. Is that correct?
Absolutely, George. That's the idea. The idea is to cross from below. Is he bleeding? Is there blood coming out? No, is to cross from below and then externalize and then work from above. I think you should be in by now.
So would you just go ahead and do this sheathless then?
Yeah, so that's why I wanted to have enough purchase here, Jay. We may put the dilator in of the micropuncture and then go ahead and take it from there. I think that's very important. I don't think you're in, Karthik. I think it's very, very important to do this. I normally do this under fluoroscopy. I find it very, very easy to stick the SFA under fluoroscopy, but obviously I don't want to radiate Karthik any more than I already am. So I think it's different ways of approaching this. I don't know what you guys like to do.
Yeah. PK, I think I saw dystrophic calcification to the left of where he's sticking. I think your probe is in the way, but I thought I just saw some significant dystrophic calcification. It may have been venous fill. Maybe sometimes just a quick cine run right there will show you dystrophic calcium. And
Hey,
if there's
perfect.
there you go. And you see that's in the area where you're seeing dystrophic
Yep.
calcium.
So I'm gonna have Karthik just advance this up to the occlusion. Yeah, there's a little stenosis there. Let me give it a little
Yeah,
back.
yeah, just
Yeah.
this down a little bit.
I believe that's it. The nub.
See, there you go.
Yeah,
You're
I
right
think
there.
I think
Yeah,
you're at the
perfect.
cap right there.
Yeah. So now
I
we're
would
gonna put the
use
dilator
inner
alone.
dilator only.
I'm gonna put the inner dilator, and then we're just gonna use a wire to try to go from below. Give us now here we're gonna go with probably a penetration type wire again from below, and give us another 018 penetration wire, guys.
Comprehensive should be good enough.
Or you can do comprehensive, that's fine.
From above, you can
Comprehensive is
always use your IVUS over the wire to see how far
fine.
above you've gone subintimal, whether you're subintimal right from the get-go, or whether you're subintimal closer to the common femoral. You've already got your wire up there. You can try that.
So Georgie, in the meantime, if you guys want, Michael has prepared a couple of nice talks about, especially about this hybrid type with the common femoral, just to go over some of the data. Is that okay with you guys while we work?
Yeah,
And
sounds
this
good.
way you can also make some comments based on what Michael has prepared.
Yeah, sounds good.
Go ahead, Mike.
Can we go back to the presentation?
So again, this is the penetration wire going in. So let's mag up for me.
Just
Show
watch
me
the
that, show me
disease
that.
Can we
there.
move the
Watch
ultrasound
disease
out
there.
of the way, please?
The disease there.
Yeah, no, I'll be careful. Little die. Let's do it.
All right, so
let's do a run that.
we're talking about aortoiliac disease. You have to also think about, when we're doing this endovascularly, how this relates to historical backgrounds of surgical revascularization. Just to recap, the gold standard of aero bifem bypass patency rates over 10 years,
me a command,
85 to 90%. However, with these open surgeries, there's significant morbidity associated with it.
It's not worth it.
We have a lot of
Once I
great
get up there,
data
we can do it.
nowadays looking at endovascular approaches for aortoiliac disease. So for the Peripheral trial back in 2015, looked at 24-month data, look at stenting
Come on.
based
come on,
off
come on.
task
Give me
A,
that,
B, C, and D.
What is it? No, fielder?
And this stent trial in particular showed great data for for all task classifications A through D, 88, 88% to over 85% of the task D classification. And this really showed that we have the ability to do this safely and carefully in a way that can somewhat relate to the surgical data. The COBAST trial looked at balloon expandable covered stent versus bare metal stents. And this data in particular showed that although for task B classifications, covered stents and bare metal stents were similar, for task C and D classifications at 60 months, covered stents were actually very, very good. At 60 months, 74.7% compared to 62.5%.
Now give me the comprehensive.
So that was the iliac.
Penetration.
And so this case in particular is also looking at the common femoral artery. And this is a very busy slide, I'm aware. But I want to show all these different trials looking at endarterectomy and different endovascular trials looking at the comparison rates. In particular, endarterectomy, as we know, is the gold standard for common femoral artery approaches from the surgical literature.
Come from above.
With great 1-year patency of greater than 93%, 5 years, 78 to 90%, and 10-year, upwards of 80%. But there are some trials on the endovascular side that may be able to help us to see if we can do something similar on the endovascular side compared to the surgical.
It's going smooth.
So in the TICO trial in 2017, I looked at stenting or surgery for de novo common femoral artery stenosis. And this trial in particular showed at 2 years that stenting and surgery was similar patency rates. Acknowledging for this trial in particular that the patency for the endarterectomy was lower than the historical standards. So the cauliflower one came out in 2022, a retrospective analysis on 1-year outcomes of thromboendarterectomy versus endovascular therapy, showed that for a large cohort of patients, that the surgical endarterectomy group for the common femoral artery was significantly better in terms of patency, about 96% over 1 year compared to the endovascular group. This study in particular,
no,
though,
no.
looked at all comers for endovascular, POBA, stenting, DCB, and
It's just gonna cross.
in particular, stenting did
crosses,
show
it's
that it
okay.
was
We
better
can always
long-term
externalize it, with
compared to
Why don't
POBA
you want to put
and
a catheter in
DCB.
from below? You want to externalize it from above?
More
No,
recent
we'll
trials
externalize it
looked
from
at
above.
interval
It's
conventional
crosses, right?
stents like
It's
the
torqued,
Supera.
torqued.
This one came out in 2024
externalize it right
and
into the sheath.
showed that these type of stents actually have great outcomes long over 12 months compared to femoral endarterectomy. Now, for the hybrid approach, we're looking at, if we think that the endo first approach with iliac is very good, the hybrid approach is looking at endovascular approach for the iliac plus endarterectomy for the common femoral. And this study in particular compared that to just complete open surgical revascularization. And this showed great patency outcomes over a 3-year time period with improved hospital mortality for the hybrid approach, greater 30-day mortality, as well as great patency for both the hybrid and the open approach.
I think we should try to put the CXI and come from above
Okay.
and try to get it in.
Yeah.
So you can see here that, with the common femoral, I think is going to be the major issue here. So we're going to try to come from above and below. So again, like Craig said, and everybody said, we're going to try to avoid that dissection of the common femoral. So now I'm going to put a CXI from below and bring it up, and we're going to try to either externalize the wire from above or below just to work. So right now we got a CXI going in over this penetration wire, which is a 60-gram tip wire from Asahi. And so I guess this is what we're going to do. I mean, would you guys do anything different? Cart? Would you go to cart this quickly? What would you guys do different?
I personally like to use a floppy wire here.
Okay.
That will make a small J. I think a wire like a Mongo, yes, if you're going to stay small, it looks like you're going to stay small.
You have it?
Or sometimes I'll actually even use 35 thousandths wires here. I know a lot of people don't do that. I've done a whole lot of cases with that. But I think if you can make a little bit of a knuckle and you don't have to push it hard, I think you may well, but I would make sure I don't keep that knuckle beyond the area.
Yeah,
of the
because
cleat.
Craig, the contralateral, I think for everybody watching, the contralateral rail this wire, guys. The contralateral external iliac, internal iliac is occluded as well. So with the contralateral internal iliac being occluded, the problem here becomes that if we lose this internal iliac, then we show me am I bending this wire? No, I don't think so. Nope, it's going. If rail, Roman. It's not going. There you go. Show me above now. No, the wire kind of jumped back, so be careful.
Yeah.
Yep. Okay. So now we're gonna now we've got a catheter from below and above, and Karthik can try from above now. Let me pull this wire back for Roman. There you go.
Yeah, so what's
careful.
everyone
This-
using?
this
So
wire's stuck.
in a case like this, I would use an
There you
018
go.
to start. I tend to like the Gladius 018. It's a little bit aggressive, but
No, I like the Gladius.
but it's got really nice tactile feel and it's got enough body. What's
Yeah.
everyone's wire choice?
The Mongo is great. Mongo 1.8 is a fantastic wire.
Yeah, I would use the same. I would be, I would not use a wire that has as much penetration power.
So let's
I'd
give us a
rather
Mongo,
knuckle
guys.
something over and slide it down through there.
Yeah, we're gonna try a Mongo here, Eric.
When you have something that has a lot of penetration power, it
catheter.
has a little bit more likelihood of going through the artery.
Real.
Yeah, Mongo's got good body, but the tip itself is
Real.
really
This
good.
And I like the Mongo specifically over the Gladius because it has that kind of transition point where it will knuckle on itself.
Yes.
So at this stage, while we're crossing, I mean, would any of you do card, or you just try this with and I know Craig talked about the 035 wires, and classically what we do here is, I don't know, maybe Raman can comment on that. What we're concerned about is really dissecting into that common femoral. Raman, you want to say a little bit about our algorithm?
Yeah, I mean, these particular cases, I think stressing the point about the fact about preserving the common femoral is kind of like the crux of this entire case. And I think there are a lot of different ways. Typically for some of these iliac CTOs where the common femoral is not included, I think you have a little bit more luxury to kind of some more versatility. Oh, and there we are. Mongo wins.
Mongo wins. Nice job. But remember, it's also the dissections we created with the other wires. Show me above. All that really helps. Creating some dissection planes. And really working hard at it. Here, you can.
I would still IVUS this PK before you put it below.
I'm with you on that. Always.
So I think the question on the cart is legit. I've done it. I've also done one where we decided to bring the lady back into a hybrid approach, and when the surgeon
Is it out? No, not
exposed
yet.
the
Not yet. Not
common
yet.
femoral in the first part of the external iliac artery, it looked
coming,
like I
keep coming.
detonated a bomb in her
the way up.
external
Yeah,
iliac.
it's out now.
Are you
It
sure?
was very,
Tell me a little lower.
it was not pleasing to the
Yeah, it's
eye.
out,
It
yeah.
made the stent choice very clear.
Roman, you wanna just
The
speak
value
the
of
word?
covered stenting became obvious to the eye, yes.
Oh, careful.
So that's a good question.
That's you,
So
that's
Sorry.
would you consider doing a hybrid of a cover
I'll go
stent
AB
with
because
Supera
it's easy for you.
Have it in the room.
especially since we're going across
Pull this wire. Pull this.
So
cap
in
around
this,
this
yeah, so this one, you know, you
So wait
want
a
to,
second.
so the
Take it.
data that was
Yeah, I
shown,
got it.
first of all,
Clamped
in the external iliac artery, I think it's a self-expanding. But a lot of these
Ibis,
trials,
guys?
the self-expanding stent
right
was
over here.
superior to the balloon expandable, even all the way up into the common
Okay, you
segment.
want me to put
Because you need to
you want me
maintain
put
the
a
patency of
microcatheter there?
internal.
Just
So the
Not
thing
just
is,
low
all of this is risk
Why?
reward,
Just put
you
a
know, it's
microcatheter.
like
You don't have
how
to keep holding the
badly do
Just
you
1
really
second.
need to do this endo at the risk of messing things up? I
Yeah,
mean,
and you
that's
still,
really-
and you still want to
On that
preserve this internal.
Yeah.
Okay, that becomes very, and you know, as we go up with a covered
It's on
stent,
this
the-
one, right? Ibis
we
on
need
this
you
one.
O1
can just-
we need
you can
018
say, well, I'm
Ibis.
going to put it right below that, but as you well
I
know,
was on this one, don't worry.
geometrically, these things are coming in at an angle.
side?
Let me feed it
And
to
so
you.
you may not
side.
cover
Yeah,
your
we're gonna be
lesion,
able
or
to
you
take
may
it. There you go.
overcover the other, and that can result in, you know, results that you don't want.
This is a 9.
Nice job crossing this. These are not always so easy, and it does take patience, but it's very important to never force these. I think the IVUS now will give you a good idea, because if you're going to get perforations occur in external iliacs in little women. I want you guys to all put that in your
What is
in
this,
your
035?
mindset.
Yeah.
That's where
it's not gonna
perforations
go
occur.
with the 8.
I don't think we're going to
You
get
give it
one here,
035?
but be prepared
You give
for it.
035, Ibis?
Regardless of what you
Show
do,
118.
have a
118,
covered
bro.
stent handy.
This is an
Overnight.
035.
I said
So
018.
you brought up the point of cot and so on. If you're going to cot, I agree, stay away
It's not
from
gonna
the,
do 035,
the
not gonna go
origin,
through
the
You can
hypogastric,
go, I
stay
mean,
away
035
from
will
the,
go through it.
if you're going to cot it somewhere in the middle of the external iliac, you can use IVUS to decide how far away your wires are when you want to do
Yeah,
something
and
like
I
that.
think, you know, a lot of us do
Shows us.
combination radial femoral approach, but at some point in this procedure, you need to be prepared for if something goes sideways. So the 8 French guide they have in is great, because you need to understand the size of
Can I have an
the
018 Ibis,
devices
please?
that you're going to need potentially. And so everyone should have one of those kits. You should not be doing any sort of aortoiliac work without one of these kind of oh shit carts, if you will, right?
So, George, I just have a question for the panel here. So now, what are you looking to learn from the IVUS? I understand, you know, your way you cross. I mean, for me, these kind of cases are going to really just work out to be covered stent, especially since the way we crossed. Obviously, we didn't disrupt that cap, you know, where we crossed from below at the level of the cap. We didn't enter into the dissection plane from above because we didn't loop. So obviously, within the body, we're maybe dissected, but at the 2 areas of entry, we're probably positively in the center because of the way we crossed. So my question to you guys is, you know, other than stent sizing, is there a question of covered versus non-covered here?
I think the
well,
top 10 things, 1 through 10 is the wires inside the medial layer of the artery,
Right.
Okay.
inside the lumen of the artery. If it's in there, you can debate and flip a coin on what you want to do after that. But if your wire is outside, you'll have a catastrophe otherwise.
Yeah, and I also think landing zone, because right here, you want to find out where you can land very precisely so that you
Yeah.
don't accidentally not cover some area that you've disrupted, or you accidentally.
I mean, for
So I teach my
contralateral
fellows
hypogastric
in a-
occlusion, that's the key point, is you're defining really your proximal landing zone. I agree, it's not too much to decide, are you, what layer of the artery are you in? It's
You
to
just
make
gotta
sure
rail
that
both sides.
you enter and exit the plaque,
gotta rail the other
you
side.
know your true lumen, and more importantly, you know where you are relative to the profunda and the
That's
hypogastric,
your bifurcation.
particularly in someone with the
Okay.
contralateral.
So
We know
you
some-
guys can see the
we know
IVUS. We're going to pull back now.
Yeah, let's take
Okay.
a look.
Yeah,
at it.
that's good. So we know this is some of this may well be subintimal, but they're all degrees of subintimal. Subintimal
the
means
plaque.
you might be below the
Yeah.
intimal, but you might be all the way out at the adventitious. And that's what you want to make sure is not going on.
Yeah, I think that looks good. As
so
long
far
as
it looks
you're
great.
inside that medial layer.
That looks great
I
so
think
far.
that looks great.
Yeah, okay. And then you
Yeah,
got-
that's really
that,
nice.
see, now I think at any point you could say you can do pretty much whatever you want, whether it's balloon, that's getting a little close there.
Close to that, right
Yeah,
there.
right there.
That's
right
getting,
there.
right there, that's getting a little close.
Yeah.
It's a little risky. zone
Back,
there.
back onto the center.
No, that's
That was
pretty
outside.
good,
Yeah, now we're back.
Okay, now we're true lumen. So now would you guys balloon this with what size balloon you thinking, and then how would you decide after ballooning? I think we should balloon this, don't you? And then decide. I was gonna undersize my balloon here, guys, and go with a 4.0.
Yeah.
And then see what's thinking me a 4.0 long 4.0 100 balloon.
Yeah.
Yeah.
You know, PK, the other thing I would do is I would go up incredibly slowly with the balloon.
Okay.
Always in these cases. And the reason being, often if a patient feels pain, that tells you that the next step may be a problem.
Yeah.
Pain comes from the adventitia of a vessel. And if you have pain as you're inflating, worry about it, because the next thing you may be dealing with is perf. Very important. And sometimes that would determine whether I would use a self-expanding or a balloon expandable stent.
Yeah, the other thing is take advantage of the IVUS, particularly if you have the ability, like you do with Phillips IVUS, to landmark. I mean, you can measure.
Can you measure the common femoral for me?
Yeah,
exactly
6.
how long a stent you need and
So,
where you're
so
going
there's
to
some
land it.
abnormal remodeling there as well too. You know, we were commenting here that, you know, you're going to have to be extremely careful when you're ballooning here because, I mean, the 4 is probably going to be fine, but, you know, I'm favoring a kind of a cover stent above.
Yeah.
Yeah, my strategy on this would be what Jay said. I would use a very undersized balloon, enough to get a track through there, low pressure, open it up enough, get a covered stent in there, and then cover the whole thing, and then you can crank it open after that.
So I'll say, I'm not sure whether you guys can see what I'm showing here on the IVUS, but right here we're in the common iliac on the right, and you see the internal coming off right over here, and now we have this short, this short segment of healthy, but somewhat diseased, external iliac, and that's just really all that we really have. So we don't really have that much landing room proximally. There is some, but then right after that, it's our occluded segment.
Flora, please.
But I think what you can do is that you can use a mix. I mean, if you need to preserve the internal, then you can cross it with an open cell self-expanding, and then you can
do the rest of it covered. Yeah.
Yeah, so we're just going to go up to where we think the common femoral, right about there probably. We'll do a picture here, DSA, guys. Okay, we're just going to do a quick DSA. So I don't want to go too much into the profunda or the, this one, I have to go further down. Okay.
Little bit
So I have to go a little bit further down here.
What kind of length measurement are you talking there? This
is a 120 balloon there, Eric. It's a 120 balloon, so we're just going to go up with this 120 it's a 4.0, it's undersized, so I think we'll be okay. And again, we went with an 8 French sheath for a reason, and we have distal access, God forbid, if anything happens. Flora, guys, let's see. Obviously, for everybody at home, we've got a occlusion balloon in the room, aortic occlusion balloon, and again, as Craig said, just going up slowly. That's just 2 atmospheres. 4 atmospheres. Just let it sit, let it work.
Seems okay.
Yeah. No bradycardia,
a little bit of
No pain.
and no hypotension, thank God.
6.
What's nominal, guys?
8.
And go to 8. Okay, that's 8.
Thank you.
Down.
Seems okay. She's taking it well.
And then we're going to walk back to 15 is where the occlusion was. So again, glow tape really helps you here. So we're just going to walk back to around 15. Yep, go up there.
Yeah, right there.
Again, you got to go to the right view, so we'll go to the right view for you. There you go.
He says the right view, he's going contralateral here. That displays the common iliac, external and internal junction. That allows him to see the origins of each.
I went up.
Go up again. We'll go up again one more time. A little bit at the top. Okay. Okay. We'll
She
take
felt the pain here a little bit.
give a little die, guys. We'll just take a little picture. Don't detach because it's still balloon is still inflated. Little die. Okay. Good. All right. We're fine. I would walk it back. Take a DSA here. So again, we've got control from below and above with the 014 wire. I'm just going to walk this out. Okay, DSA, guys, inject.
I think that's that's a really excellent technique there, of just going up really slow and taking your time. I think that, if you can gradually stretch these vessels and they're tolerating it, yeah, that's a nice result starting. I mean, you're starting to get a great result right there.
Now let's see what's going on here.
The question is it mandatory to use a covered stent in this particular situation?
Do you want to find out?
If you use a self-expanding, if you use a long self-expanding, you're not going to bust
I had one
anything up.
once that it was the wire was probably a little subintimal, and the patient went back to the recovery area, and about an hour later it popped.
But there is a tiny, tiny area that will got closed.
It's
Go
very
back on the
minimal.
balloon pick.
One spot where it's kind of suspect. The
Yeah,
rest
and we don't have a perfect, we don't have a perfect common femoral yet either. We need to see what this comes out.
Yeah.
There's still a high-grade residual right there.
Yeah, yeah.
So let's get this whole segment open, look at it, then we can reassess and make smarter things. See, I don't mind a stent in the common femoral if it does not involve the profunda and the SFA. That is a whole different animal, in my opinion, than if it involves those bifurcating vessels.
I agree with you, and that's what Jay and I were just talking about. I think there's enough of the mid to distal common femoral that's okay, that's patent, that you can put a stent in that proximal common femoral and stent back up there. I don't have a problem with that.
Yeah, I pulled back. Okay, go up there, guys.
And some of the questions that people had was, could you re-access if you put a stent? I'm sorry?
That's okay. There's a lot of dogma about common femoral stents, but frankly, has anybody seen anything that says that putting a stent, even throughout the, I routinely will put it halfway down common femoral, routinely.
Yeah, I agree.
To above the bifurcation. But even then, I mean, it's like it's a voodoo thing, a horrible thing to do. Is it really? I mean, has anybody ever shown that actually even crossing the profunda, which is, I'm not advocating it, but we've never really shown that it's a bad thing to do.
No, I agree with you, Kenny. The only issue I have is re-access time, re-access. And so if you can have an area to re-access, and I think you can get back through a superior stent a lot easier than a slotted nitinol tube stent, because that'll catch on things. It acts like a barbed wire fence.
You can access right through a stent. So I'm not advocating for it, but I'm just saying there's a lot of dogma out there, and
Agree.
that we don't know.
Agreed.
And I know if you have to do an endarterectomy or something like that, and I get it.
Expert opinion.
Low IQ academic over here, but I think the real challenge or the problem that we worry about and that we see regularly is it's not so much reaccessing, it's when these fail and you lose the profunda to the SFA collateralization.
Right.
That's where the risk of major limb loss really goes up regardless of time to revascularization or strategy of endo versus open. And so that, I think, is where...
So the front is the lifeline of the foot, no question about
that. So
that.
guys, for the sake of time, just a question. I don't know if you saw the angiogram post-angioplasty, and Kenny, thanks for the great comment. It's true, I agree with you. I think common femoral stents do quite well. And you can see here that the common femoral hasn't fully expanded, but clearly we have great flow. Profunda is unaffected. We have a landing zone above that area. I can IVUS it if you'd like again. And then what I did was I went backwards, and obviously we took a delayed cine here, but unfortunately because our timing was off. But you can see the vessel there. You can see the external iliac is open, and there's a little landing zone, like Dr. Raman said about the ostium of the external. So the question now is, would you re-IVUS and re-treat that common femoral, or would you guys go ahead and put a covered stent in that area?
I think you can probably go straight to stent.
Yeah, I would stent it.
But Craig, is there any role for atherectomy, or Kenny in this case, or George?
No.
Well,
Well, wait a second, guys. I'm talking about the common femoral.
The common femoral, I think
Why complicate?
I think PK is talking about the common
matters?
femoral.
DSA. I'm
it's
just talking about
interesting.
the common
I would
femoral.
not probably do it, but I will tell you there were some articles suggesting not such a bad result with that. Tom Zeller in particular published a whole series on that. And his series was actually fairly impressively
What about a
good.
serenator?
But
Yeah,
I do
that could
think
be
it
good.
matters if you're going to extend the stent into the common femoral, which stent you place. I really think that makes all the difference in the world. That's the zone of a superior stent, period. And people ask, even if you cover a good bit of the common femoral, people ask, can you reaccess? And I can tell you, you absolutely can with fairly big stents. I've personally put an 8 French through one without a problem, but I have seen a 10 French placed in Germany.
Give me a serenator,
through
guys. A
superior stent.
7.0 to a 40. So I want to serenade this, Craig, at the level of the where we're actually you could see that tight stenosis. I think serenaded. Raman and I are voting serenaded. Karthik doesn't feel like it's appropriate. I think Karthik feels we're in a dissection plane, but I think in the IVUS it shows in that area we're not. So I think we're just going to put a short 7.0 serenader, 7.0 40. Or 6.0. What Raman measured? Yes, 6.0 serenader. 6.0 serenader, and then we're going to see how the flow is.
6.0 short, guys.
6.0 short serenader.
40.
And what is that going to do? Tell me what that's going to do.
Yeah.
I think, Craig, Kenny, what I believe that's going to do is it's going to break up this dissection plane right there and not necessitate stenting. I think you're going to get a great result in this area. There's a fibrotic band, I think that's right there, that's preventing, we can do an IVUS, but that's preventing that area from expanding. So I think if we put a serenader in, we're going to be able to serenade that, and then we'll go ahead and can use the DCB in the common femoral and a covered stent up top. That would be my idea. I don't know if that's going to work.
My only concern is if anything goes wrong with that, you extend any sort of little dissection, now you're creeping down into the bifurcation.
Exactly. So, one of the problems with it, I agree with you that this is a great one for Supera, but you really have to put that in from the other side, Craig, because you don't know where the back end of the landing zone is going to be.
100%. You can deploy distally very accurately. You cannot deploy proximally very accurately.
So I mean, I don't know if they have access on the other side. I didn't see it. Yeah, they do.
Yeah, we're up and over. He's up and
We do.
Yeah, so you can go up and over with a Supera from the other
he's not
side.
just up and over, he's up and over with an 8 French, so he can even inject around it to see the side.
Yeah, so so PK, we in Boston like to keep it simple because our IQs are not that high. Now, and I heard about that this morning. From Eric, but I don't know. I would probably just do that and keep it simple, stupid. Just put a Supera in from above, and the bigger question to me is what about the origin of the external? Because I don't think the origin of the external is normal. And are you going to try to nail it, or are you going to try to keep the flow intact and put a stent overlapping the internal? That's what I would do. But I'm just,
So I have a suggestion here, because if I were doing this, I would use a very short Supera distally. We've not wholly prepared the rest of the vessel. I would stay fairly short. I would make sure that I nail this distal area. I would balloon it first, a little bit bigger, but then I would put a Supera right there, and I would post-dilate that. Then I think you did not have a lot of pain up top. I might go with a regular stent, a self-expanding stent up top. I think you could bring that up, even if you crossed some of the internal, you wouldn't lose all the flow in it. I would try not to cross, but I think you have a little room.
I think this is like the cornering cases. Trying to nail that is going to
be difficult.
Just go across with an open cell, big self-expanding, and you're not going to compromise the internal.
But if you're going to try to cross it, again, use a short stent when you do it, because a short stent you can place a little bit more accurate. What's going on there?
Looks like the thrombus that was there, they moved down into the SFA.
Wow.
So we're going to get a penumbra. Guys, grab a penumbra for us. So again, this is a great case because now you see the iliac with the layered clot that obviously was liberated into that area. So we're going to go with a 7.0 or an 8.0 penumbra.
So this is something I see quite a bit with some of these occlusions. And a lot of times it's a hibernating core of thrombus, and so I often will do a thrombectomy if the wire is really easy. Especially in that segment where they're intraluminal. That's just all
So we have access from over
below, so it doesn't
There's a
go
high
into the
rate
SFA.
stenosis, and then there's thrombus kind of
No,
developing
that's what I'm
around
saying.
it.
Put a balloon, obstruct the thrombus.
I don't think it's this way.
I think
So-
this is the thing. I think
so
there's
the
so
question
much
here-
we underappreciate.
I'm sorry, guys. So there's a little discussion here about getting sheath access from below and balloon including the SFA. I don't necessarily think is needed. I think the penumbra will get this out. We're going with the cat. We're going to go with we got an 8 French penumbra, please. All right, give me a liberal. I'll go with the 7 then. 7's fine.
What happens if you aspirate your? How big a sheath do you have in below?
We just have an inner dilator.
We just have a dilator.
Or just because the other thing you might question is if you put in a sheath there now, because you know you're in the vessel, you could potentially suck this out.
That's what we're discussing here, Craig.
That's what we're discussing here.
But that's the whole idea. That's what we're talking about. But then you'd have to put an 8 French sheath in this vessel from below to probably get that goober out.
Yeah, that's pretty big. I thought maybe you had a 6 French, and then I would have suggested just do one
Well,
simple
we could put a 6 in, Craig. I mean, but again, do you not think this will come out from above? Do a roadmap?
I don't think
will.
you need to.
Huh?
Just take the bolt 7 down and just suck it right
Yeah, I
out.
was going to say the bolt.
I would probably do exactly what you're saying. I thought you had a sheath in. I was just saying if I had one, my first step would be to aspirate.
So do we want to take bets on whether the penumbra is going to get it out? Whether aspiration alone, or do you need something mechanical?
We're going to use, you're talking about the separator? Is that what you're talking about? Or
No, I'm talking about, pounce or...
pounce? Yeah, I have a pounce. We have pounce too.
You have to put
Excipio or
this outside
pounce or
again.
something like that.
Yeah.
You have to put this
I
outside.
would always try aspiration first before complicating
Yeah.
it with additional mechanical
I agree.
features.
I agree.
So-
I mean, I agree. I'm taking my bets though, just to, what's your bet?
I think
I'm going to bet it. I'm going to bet.
Let's
bet
Ibis, guys.
It probably is going to get it
Ibis
out.
again?
I want Ibis.
yeah, he's got an 8 French. He could go with an 8 French bolt system. Very little blood
Yeah,
loss. I
yeah.
think
There's a
good.
lot of
I
choices
think-
here. There's an imperative care that's incredibly powerful that would probably get it.
Yeah, I think that might work.
So the idea, so we're going to IVUS this to make sure that we understand what we're seeing. So I'm going to go down with an IVUS while we're getting the penumbra ready. And I think this is part of the fun of doing live cases with you guys. I get such great ideas, Flora. And,
Go live on the IVUS?
And we're just going to go forward with the IVUS here and take a quick look.
You're alive.
See what happened here, because you saw that everything was expanding very nicely, and then you're having this issue. Where's my IVUS? Do you see my IVUS?
No, not yet. Not yet.
I think one of the things
Not
we,
yet. Keep going, Bigger.
Sure.
Yeah.
While you're there, why don't you suck out the rest of the debris all along the way?
All right, we're going to go live with the IVUS. Going to come off roadmap. Okay. There's your IVUS. So that's your SFA, guys. So I'm just curious on what it really is. Recording, coming back slowly. So
Right there.
there's your goober. Looks like plaque, guys.
Yeah. Looks like all plaque.
I think it was just a plaque that was at that.
Just
that
plaque
distal
shifts.
reconstitution.
It's just
That
plaque
just
shift.
shifted down.
This is, I think.
I don't know. It's all dissection and plaque.
It moves. It moved. It's
It
not
moves.
just plaque. It's gonna be-
All right, let's get the penumbra since we have it
You
open.
can't even tell the difference, right? Because it's just, no.
So now we're going with the penumbra.
It's plot versus hard plaque.
So it's not.
So, again, for the audience, for a long time, the aspiration devices were simple aspiration. And Penumbra came out with a concept that allowed you to
Give another 1,000.
have some blood saving. So it senses clot, it
You guys know where you're
aspirates at that point, the lightning does, and it turns off the aspiration, if it doesn't sense clot. So there's a lot less blood loss with it. It's a very novel
I
idea.
think the thing that
Open up
just
the
bothers
port.
me at this
Open up
point
the port on the
is
top
it's
back.
probably not going to be completely clean. I think there is a little bit of a flap. I think you've now turned the 1-0-0 bifurcation into a 1-1-1. And
Rail?
it's
You got it? You
becoming
got it.
complicated.
Rail. I'm going to rail it here, okay?
That's
All right, we're going to come down.
Kenny had a good question earlier. I didn't know he was
One
kind of
second,
half
one second.
joking
Show me
of
above
cleaning
this.
out
One second, one second.
residual debris. I mean, when are you guys activating
Show me above, guys.
whatever aspiration catheter you're using? Are you doing it at the proximal lesion? Are you advancing it
Just start
to
here.
the
Start.
area of concern and then working back? What's your kind of strategy?
So
for
with,
this?
with penumbras, you want to start very carefully proximally because it pulls pretty well.
Yeah.
So I don't want to immediately engage it and shove stuff. I mean, it's pretty powerful.
So I
it'll
am,
stand a little
I'm
bit
already-
upstream, especially if you activate it and give it about 20
Are we
seconds to
activated?
start circulating. It has pretty good force.
You got a fluid to fluid, guys. Yeah.
No. We did.
I think this is overwhelmingly probably clot, just looking at it and putting everything together. It's moved, like Eric said, it's a clot-like substance. And it's a joke from some of our travels in China. But I do think this has got a good chance of cleaning this up. We know in long occlusions is debris, come on. Almost always we know that. And we've historically kind of ignored it. Eric and Tom Davis just wrote a very nice paper that has been published in, I'm sorry.
Is your flushing?
Yeah, in vascular disease management,
Should you hold this
just
and then do it?
3 months, just this last month in March. And, debris is, I think, ubiquitous here.
So we're having a technical issue with the penumbra, like,
Uh-oh.
Let's see here.
Where's
So
your
which penumbra device did you choose, PK?
We have the 7
7
French here. We have the 8
7
French
French.
Liberon as well.
Okay.
Yeah, I would
Yeah,
do that.
you know,
Isn't that supposed to
Greg,
be up in the air?
PK, you know, you could do Turbo
Up in
Elite
here.
and clean everything out. You can have atherectomy, you can have everything and clean everything out with Turbo Elite.
Yeah, go. PK.
Okay, fine. It looks like it's working. Raise that up in the air, please. Jazz, I got to push back. What you did to us, you delayed us, Jazz. Look at this case. Where I mean, you guys are doing pot there, and other things we're doing like thrombectomy. Kind of cool, you know.
So it's working pretty. Is it working now?
It's working beautifully right here, Craig, and we're going down very, very slowly. George, I mean, and obviously, Jay, you guys have so much experience. Is this the kind of technique that you would do? Is there something you would do different?
Yeah. I mean, with the bolt system, obviously, it's using a modulated saline to essentially send sonic pulse down there to change the friction of the thrombus to allow more to more easily be ingested. But then if you end up in a situation where really you're not getting a lot of progress because it's so hard, then you can hold the go button down for about 3 to 4 seconds, convert it over lightning mode, and then just sit on it for 90 seconds and then try to pull it out, cork it, remove it.
Yeah, I think because of the new algorithm, you don't have to worry about staying on. It's only going to work when it's in contact with something, so you don't have to worry about taking out a lot of blood.
This noise it makes usually is when it's in contact with the thrombus.
Yes, correct. That's the bolt mode.
Yeah. If it's an open vessel, it usually is very quiet. And as Jay said, like this is where we usually keep it there for 90 seconds, just to, as long as it makes that noise.
The 90-second part, though, is like really, this is, because it's obviously modulating the aspiration, but when if you want to suck on something, if you want to cork it, that's where they use that so-called.
PK is actually doing it, right?
Yeah, but I'm worried I'm pushing it down, guys. Give me
so if you want to avoid that, then like you hit the stop button and then hit go for 4 seconds, and it'll convert it from bolt to lightning. And then at that point, you can actually try to extract it out as a noodle.
I think we got it.
We got it.
Yeah.
Go up here. So I'm just gonna pull it on the.
1 second.
No, do you want me now? I agree with Kenny. We should do it on the way back as well. Let me go up. Let me pull it back and then come forward on the external iliac. Show me above.
Yeah. Now, from a technical
Flora?
standpoint, just make sure that you are
Show me above.
coming all the way out and bleeding back, so your next injection isn't reinsertion of thrombus.
Yeah.
Start again.
But you hear the slow clicks, so that means it's now an open vessel, so
an
the
open
blood loss
vessel,
is a lot
PK.
less, so it's not going to be aspirating as much at that point.
Yeah.
Yeah, right now it's very slow clicks, Jay. I'm just gonna run it through. Always
Yeah, so
taking.
that's just open vessel really at that point.
Yeah. So PK, we're gonna stick with you for the rest of the thrombectomy and see how that turned out, and then we may have to break away and then come back.
Yeah, absolutely.
Okay, but we want to see what happened here, because Kenny took all our money, so he, if I'm right, he owes me.
No comment. How are those Yankees doing, by the way?
They're doing very well, Kenny. I think you're right. We might need the pounce.
Kenny, the Yankees are doing well. The Knicks are also doing well. So
Flush forward, guys.
I think Celtics are doing well too.
Good.
Yeah.
Let's do a DSA. Let's see what
I
we
mean,
got.
there's a lot of different aspiration catheters out there now, and it's really hard to figure them all out. I mean, which one? I mean, Penumbra was the first, but there's others that have come out. I mean, you're right. The Liberant by Medtronic, the Prodigy catheter from Imperative Care.
So we just have pushed it down.
Yeah. So this is where I would switch over to lightning. So I would go all the way down, sit on it. So you hit the go button for 4 seconds,
SFA.
and then you'll be on pure aspiration mode.
Let's go down with the lightning. So we'll do that offline, and then we'll come back to you. I think what we're going to end up doing is, you can see the common femoral is looking pretty good. So we're probably going to DCB the common femoral, and then we'll figure out what we're going to do with the external iliac.
Okay.
PK, the other option is just put a short stent in that proximal SFA and just stent over it and be done with it.
I totally agree. That's all. I totally agree with you, Eric. But I think right now we're going to give it a shot with this lightning mode that Jay's talking about. So Georgie, oh my God. So let me tell you. So a lot of fun, George. A little external iliac case. turned into a lot of fun. So anyway, so we embolized below, as you can see. So we did the penumbra, nothing came out. So we got access from the foot. Put a small a balloon up into the SFA to see where the flow was. Hold on, if I can play it, there it is. So you can see that. So you can see that right above is the clot. So we knew that. So then we put a balloon up, and then we penumbra it again.
Balloon to see if there's no flow.
And that's the balloon up, just to show that the balloon is there. And then we found that there was this lesion at the level of the SFA, which was probably causing where the clot was stuck and was getting pushed down. So this was the lesion. So we ballooned that lesion with the DCB. And then we went ahead and put a covered stent into the SFA, and look what happens. So when we did the covered stent, everything embolizes into the internal iliac. So now the internal iliac is gone. We've got flow in the SFA. We had to use a Conquest 8 millimeters at 60 atmospheres to open this covered stent. So it was so difficult to open. We haven't IVUSed yet. And then we had this. Now the next step is, now we Fogarty'd it. And I want to show you, give me a DSA here, guys.
Watch your legs.
Uh-huh.
You want to go left?
So we Fogarty'd it, and we ballooned the internal iliac, and I don't know what we're going to get. We're going to take a look here. We still have a balloon up in the external iliac now. Oh, we took it down, right? Yep. Let's see, inject. So that's the flow. You can see the profunda fills, but the internal is my worry now. So now I've converted this patient into an internal iliac, probably a buttocks claudicant, but I'll see what I can do here.
No contrast.
No contrast. Hold on.
I'll do manual image.
So right now, you guys happy with? So we did DCB of the common femoral, avoided stenting of the common femoral, which I'm not a big fan of, and then we did again a Conquest and an 8O balloon in the external iliac to do it, and this is what we're left with our internal iliac. So now the question is penumbra of the internal iliac, continue Fogarty, or what do you think?
I mean, you've got the bolt 7 there. You can just track it right down to there. Just let it sit for a bit.
Yeah, that's what we could do that. And that's what we'll probably end up doing here. We're going to take an 035 wire down, send the bolt down, and see what's up. So right now, look, we're just going to check, make sure I just want to show you one technique that we use since we had the sheet below. We put a balloon in the. I guess did we save that on roadmap? I guess. I don't know. Show me the. No, you can't do it on this. Maybe you can do it on this. We actually balloon occluded the external iliac. There we go. Yeah. So we balloon occluded the external iliac from below, and then we went ahead and Fogarty'd aggressively the internal iliac, and we're able to obviously prevent any embolization or toothpasting out into the external. So Jay, you were right. The penumbra did work. It went down, but I think having the balloon down really helped us here because we now have toothpaste back into the internal. And now I'm going to go with the penumbra into the internal. Can I get a Vertip catheter, guys? Let's just take pictures.
Yeah, so PK, just for the sake of time.
Sure, of course.
So we can let the CTO guys get back to it. So you're going to try to work on the internal iliac, get it a little more open, and then are you going to end up stenting across it with a self-expanding, or are you hoping to avoid that? Or
you know, maybe if our surgical colleague is there, he can advise me. You know, in terms of the contralateral internal is gone, guys, as far as we remember, right?
Yeah, contralateral internal is gone.
Contralateral internal is gone, and now we're dealing with this. How aggressive should we be here, et cetera, et cetera. Go ahead, inject. So we're just going to show you the flow all the way down to the foot. So you can see that we have good flow.
Great
and,
blush.
you know, so much so that we have a tremendous amount of venous blush there.
All three vessels.
So all three vessels are there. So now the question is, you know, how aggressive should we be here with this internal? Would anticoagulation alone work, or should we go after this very, very aggressively?
I would probably not go after it super aggressively. There's a lot of tortuosity there. I would worry about further damage. There's some flow. I'd give anticoagulation a chance.
Check the first internal iliac picture, PK.
End the case. What's that? Oh, Eric wasn't what the ACT was, but were you doing?
ACT was 350.
300.
So this is the first internal iliac picture. You can see that that's probably stuck at that stenosis.
Okay. Yeah. All right.
So we'll decide here, and we thank you guys for the opportunity. extremely difficult case. And thank my team for putting up with me during this case. So thanks again, you guys. I really appreciate the opportunity.
Great job.
Thank you.
Thanks
Thank you,
again.
guys. Thank you. I think I would go into that branch.
Let's take a look. Okay, give me a twin pass catheter, guys.
Ping pong.
Yeah,
Flora?
hold on. I will say though,
Flora?
all of the buttock branches
Before we
are
cut
higher
back
up.
to
You have the
Those
floor.
are- Those are
We'll let him
already
work for
open.
just a minute.
All these
Brian,
are
you
just
wanna
going
come
down
up
to
and,
the
give your
profunda
talk
and the
on
SFA.
Justifying CTO PCI. We're gonna.
Let me put the
we
twin
got
pass in,
deep
and then
into
we'll
the
decide
CTO
together.
techniques quickly, and so
yeah.
we're going to back up just a minute and
Can't
talk
quite
about
see.
indications and justifying CTO PCI.
There we go. Now we can see. Okay. Okay, good.
That's it.
That's where
That's
we
the
were.
branch.
Okay,
Yeah.
good.
See, that's where the stenosis.
Now give me a twin pass catheter.
Watch your legs, Vika. Watch your legs.
We'll
Watch
talk
your
about
legs. Watch your
justifying
legs.
No, leave it
It's gonna
there.
be
This is a
pretty
good view.
small, huh?
This is a good view.
Stefan kind of
We can at
alluded
least see it.
to what we deal with
You want to take,
CTO operators.
you want to
So
do a
no
twin pass on this?
disclosures. I'm gonna
Just to
start
see
with
where
the
it is.
case. We'll go through this.